Emergency Physicians Monthly, and you are listening to, watching EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us. And today I have my dear friend and longtime colleague, Mike Silverman, with me. And thanks for joining me, Mike. And we've always had great discussions. Your insight in Director's Corner is nationally known over the last decade or 2 decades or so, and your wise wisdom. And I've been following your Facebook Friday night reports. I'm not sure what you call them, but you started writing them about, gosh, a year ago? Was it a year ago?
So, thanks very much for having me, Mark. It's I've been writing for EP Monthly since about 2007 and writing Director's Corner since 2008. So as we get into that, it's a long time. A long time as we are in our 3rd decade, or 13 years. The Facebook updates I started doing at the very beginning of the pandemic. I think the first one was on March 13th of 2020. Wow. And maybe March 11th, but in that second week of March. And it took me a little bit to figure out how to brand them, I guess. And I call them Friday Night Updates from the ER. And so it is a weekly kind of update on what's going on in my life and what's going on in the local emergency department and hospital community. And probably over the last year and a half, what I've tried to do is also then focus on some of the research that's out there. I am not an infectious disease specialist. I'm not an NIH, but
sure,
for non-medical people, I think I have infinitely more access and the ability to interpret data, calling on some friends and colleagues as well to get information out there and hope to deliver, kind of a non-political view of what's going on.
Those of you who don't follow Mike on Facebook, I would encourage you to do that, simply because I think that you would enjoy chiming in, giving your 2 cents worth and perspective from your locale. Mike's over in Arlington, Virginia, and it may not be the same in Topeka, Kansas, or New Orleans, or someplace else like that. And so and you've developed quite a following, actually. I think you have a pretty large number of people that are currently following your Friday night updates.
Yeah, I think it's funny. I have probably 600 followers on Twitter, and I think I have 6,000 followers on Facebook.
Yeah.
I don't know how many of them actually read anything, but there's a lot.
No. I can tell. They read you all the way through.
And sometimes I'm wordy, so that is a solid 2 drinks on a Friday night.
Well, that's fine. It's unvarnished, and yet at the same time, it's very lucid, and it's your typical kind of easy readable style. So I encourage people to join in with Mike's Friday night updates. In that regard, then, I'm going to throw out, I kind of warned you that I was going to ask you about this, so I gave you 30 seconds of warm up. But the governor of Colorado just kind of told the world, even though he's a Democrat, he told the world that the pandemic is over. It's over, and people need to get back to their lives and live normal lives. And I guess that's he's going to do away with the mask mandates, and they're not making, I think, vaccines are optional or a personal choice, and kind of a more conservative position. But that's the position of the governor currently of Colorado. On the other side of the pond, you've got Boris Johnson, who just recorded the first Omicron death, and as a result of that, or in anticipation of a massive increase in the Omicron variant in England, they're planning to do a complete shutdown. I mean, just the exact opposite. And I'm just amazed that we can see the world, that people can see the world through with such different lenses. And I know, and I'm not really, and what I'm going to throw at you is not necessarily your personal view, but how do you handle situations within the department where you have physicians and staff who see the world through a different paradigm?
So let's just hold there for a second before you kind of get into a specific question. And let me respond to kind of this dichotomy of views in kind of where I have to come from as a medical director. So first off, throughout this entire pandemic, I've been really glad that I'm not in politics and that I'm not responsible for getting business back or making payouts or worrying about the unemployment and getting people back to work. I don't have to worry about that. And I don't have to make healthcare decisions or decisions regarding where I stand on COVID based on all of these other factors. I can focus on health and getting our department ready. So whether
Yeah.
we lock down or we put everybody back and say, go back to your life, you know what, as an ER doc who's seeing COVID now a lot more the last week or so than I was a month ago,
Yeah.
I know COVID's not over. I know we're going to be dealing with this for a couple years. And my goal is to, make sure that our staff is safe, make sure that we have the supplies, make sure we have the ability and the capacity to care for the patients that are ultimately coming in. I've worked a bunch the last few days. I've seen a lot of pretty sick COVID people, and our ICU starting to fill up again. And so no matter what a politician says, COVID is part of us and part of healthcare for the foreseeable future. And so I think we have to respond to that and then control what we can control inside of our environment and focus on health and staffing and supplies and capacity and knowledge. With that, now I'll kind of let you get into.
Before you go forward, I want to just simply say I agree with you. I think that COVID is never going to go away. I think the epidemiologists now are really talking about when it will be termed to be endemic, when it is just like the flu, and not flu in its severity, but flu in its frequency and its and when every year we see a new variant, and so how do we handle something like that? So now I think you're right that it's going to be around forever. I don't think it's ever going to go away at this point. Frankly, I think we'll see it every year. And I posted a joke on Facebook the other day about somebody had a booster card. When you got 10 boosters, you got a free Subway sandwich.
I missed that on your post. But I think boosters are a part of our life, just like flu and everything else, and it just kind of is what it is. And I'm not going to stress over that. And I agree that we are in this transition to endemic. Certainly the Omicron variant and where we expect the numbers to go over the next several weeks, I think is extraordinarily concerning to me from a healthcare perspective.
Yeah. Okay, now get back to the question here is, okay, because I have the freedom in the guise of fiction to wear a lot of different hats in my night shift. People who don't realize, oftentimes they will write me and say, you were crazy to say what you did or to treat the patients the way you did, and I have to go back and remind them this is fiction. Okay, it's just a construct. It's a way that we can talk about things that would not necessarily always present exactly as that patient or the conversation with my wife. The hilarity is the times that my people have met my wife have talked about the conversations that we supposedly had, and she dies laughing. Of course, no such conversation ever occurred. It's all in his twisted little mind. And but it's a construct for us to kind of grapple with the two sides of one of these issues, and one of them has to do with treatment. And Mike, not Mike, Bill and Salim, we're talking in the last issue about. I always get confused whether this is the one coming out about ivermectin.
I'm the same way. I can't keep track of what I've written, what I've submitted, and what's about to come out online.
We're months ahead in our discussions, and so I don't know if it's actually hit the street or not. But when you look at the different sides of things, and so, but in one of my night shifts, I've actually proposed, actually writing, if a patient wanted ivermectin, just simply say that there's research on both sides of the question. Some of my colleagues feel the research is more solid to not use it. Some are likely to use it, and I take kind of it's whatever you want to do. I'll help you in that way. But my understanding is that some people have gotten in some real trouble doing that, and that's what I want to throw out there. The viewers, the listeners of EP Talk, they may be in a department where the the feelings are strong in one way, either treat or don't treat. And how do you handle, as a director, how do you handle people with different views? And we don't want to get into politics, but we want to talk about medical respect or medical the idea of shared decision making and that sort of thing. How do you do that? How do you handle that?
Sure, and I think we do that for a lot of things within our system. So, let's say I have, let's do antibiotics for URIs. And if you have,
Good choice.
Give you 3 examples. So we'll do antibiotics for URIs. If I have one doctor who's handing out a Z-Pack, like a Z-Pack for everyone with a cough, and the patient comes back for the 3rd time in 3 months and says, well, I saw Dr. X the last 2 times and he always gives me a Z-Pack, and I tried to have that discussion with him, it puts the rest of us at a disadvantage. And so you can, example number 1. Example number 2 is, I want to make the process of a lumbar puncture as painless as possible for you. So I'm always going to do it under procedural sedation. I'm going to give you propofol. I'm going to put you to sleep, and I'm going to do that procedure. But is that the standard? Is that the best for the group? And then the third one I'm going to do, because it's the biggest one that we've really talked about in my institution, is opioids. Are we using Dilaudid or not? Who gets how much morphine as a first dose? How do we handle pain management? How do we handle oxycodone prescriptions? And so it's something that we've tracked, and we've discussed at least 2 of those things. Now, we haven't discussed the LP under procedural sedation, but I am aware of cases where that might happen. But where we discuss it a group and say, this is what we think the best practice is, this is our practice, what are we going to do here? What's the culture of this institution? And if you want to get away from Dilaudid, like a lot of ERs have done over the last 5 or 10 years, you need everybody on board for that. So if I have a provider, and I don't know if any of my docs have given.
Why do you have to have everybody on board for that?
Well, I think you have to have some consistency among providers in the department for what we're trying to accomplish. And so I'm a big believer in getting everyone pain medication. I also, as many emergency departments, have cut out Dilaudid because you have a lot of people that come in, and we think you come in more frequently. And certainly when you and I worked together in Baltimore, we had a lot of people that for IV Dilaudid. And so you don't want to put providers up against each other. You need some consistency in management as what's going to be defined as best practice. It doesn't mean that you can't have kind of your own independent thought. And I think there's times where you might give Xarelto and I give Eliquis, or you say, hey, I'm going to use Lovenox on this DVT and we're going to have them follow up. I think there's a lot of opportunity for independent thought in what you think works best for your patients. But in the big picture, probably having some consistency within a group on some of these issues, and then having that discussion at a staff meeting. So you get everybody together. Here, where do we want to stand on this? If somebody wants to do it, I haven't been in this position. Would I turn them into the board? I don't think so. I think it's kind of their decision. Do I think some of my docs have clearly been asked for some prescriptions, whether it's a Z-Pack for a cough or ivermectin for COVID, and I leave it to the individual doc to make that decision, because we don't have so many people coming in. But I think it's
you're saying this for you individually. Do you think across the country, I was pretty surprised that ABM took kind of such a hard stance on their quote misinformation without really defining what that misinformation was, about talking about reviewing somebody's board certification. And I think that there's a lot of people who are out there working right now who would say, gee, I really wish I worked for a guy like Mike, who has, who's, what I'm saying? Is it, you talk to your staff. You don't lay down rules and laws and say, toe the mark or I'm gonna, kick you out. And I think there are some guys out there or gals out there who are in departments where maybe the director is more strident. And how would you tell them to handle that?
I think all of us, as we have our leadership view, and I think, your docs, people don't leave their job, they leave their boss. And so if you're a boss that's not going to have good relationships with your team and be able to communicate and understand and respect differences, I think you're going to have a problem retaining your staff. And so I think that's just always been my leadership style. You've
Yeah.
read enough of my stuff over the last 15 years that
Yeah.
I am a kind of realistic leader, and I want to kind of recruit and retain my people forever. And that means developing, mentoring, and providing feedback and having these discussions.
Yeah.
That said, I also recognize that within medicine, things have changed so much. You go from, hey, convalescent plasma is the greatest thing on earth to convalescent plasma doesn't really work. I don't know what's going to be the best treatment in 6 months because we now have other research that probably remdesivir isn't as good as we thought it was.
Yeah.
So I think on a national, I think there is an issue with misinformation. And I think there are clearly doctors who are out there making YouTube videos and promoting stuff online that 99% of us would agree is misinformation and inflammatory. And I think that's dangerous.
Yeah, silver bullets. Yeah, while I felt that people had the option of using things, you still hydroxychloroquine. I was on the fence about it. Read some of the initial research, and we went back and forth at the editorial board meetings, and Salim, we came out with a bunch of different studies that suggested probably it had little or no effect. Certainly, if it was given late, maybe. If it was given early, maybe. And there were some, retrospective studies and things. I kind of went with the flow on that. I don't think though that I would probably, I would offer things to people that if they thought that was going to be, I've done placebos to people if they thought it was going to help them and I didn't have anything else to give them. But the animosity in medicine right now is pretty thick, and I'm just hoping and praying that somehow we can get that middle of the road, or the take the temperature down a little bit in medicine and in the arguments, and get back to rational discussions of science.
So I agree with you. I think the temperature is high, and we have to get back to that discussion. And I appreciate what you're trying to do. And I know, Bill Sullivan and Salim are, writing a lot of these tete-a-tete things. I think it's because Bill loves to argue so much.
So yeah, he's a lawyer.
Exactly.
And Salim is a dyed-in-the-wool researcher, so it's the perfect duo.
And so I think it's great. But when I have questions, Salim has been a resource to me via phone and text and email so much over the last year and a half as I'm trying to understand the data or the number needed to treat and what's going to matter. And, so I think there's lots of really smart people, and those are the people that we should be listening to. I think there's other people who are taking advantage of a platform and are super dug in. And what I don't understand is, why are you picking an item and then digging in so much? And I think, hydroxychloroquine had a, I have friends who early on in the pandemic, ER docs, who took it because we thought it might work. They swear that it helped them. The data doesn't support that. Nobody's really giving it now. But whatever made, my friends better, I'm all in favor of that. But people remain very dug in on stuff that we shouldn't be dug in about 2 years into the pandemic. It's kind of the mask or the vaccine or other stuff that seems very common sense right now with a lot of data to support it.
Yeah, exactly right. I think that, and I know you are, with your Friday night updates, you are kind of, certainly in your area, a local authority. I mean, people are listening to what you're saying, and what Mike Silverman says, I'm going to take to the bank. And I think we,
I think it's a little funny. You never want to be a famous ER doctor. The famous ER docs I know are you and Judy Tintinelli, and highly respected, been around forever. And particularly with Judy, super academic. Nobody's ever going to question her.
Right.
I'm the director at a moderately large site in Northern Virginia. I've been around the block a couple times, but I have a pretty loyal following, and I've gotten to meet a lot of people who are very appreciative of what I bring to the table. But those posts are a lot of research and understanding and talking to Sal and trying to do my best to kind of distill it down in my 6th grade. I write like a 6th grader.
I don't think so. No, I wouldn't say that.
sixth grader, so I bring it together and kind of get information out there. And I try really hard not to put the politics in it and just kind of spin the data. But we all know you can spin numbers really any way you want.
Right.
I think there's a lot of smart people that are producing things. And I think, you know, to back up a step, as we look at what's happened, whether it's hydroxychloroquine or convalescent plasma or remdesivir and Decadron, which is a winner, obviously.
Right.
But so much science has come together so quickly. And if you think about, you know, Delta really kind of popped up in mid-July. In this
Right.
past week, I wrote a lot about a lot of Delta studies, you know, particularly out of Israel when we're looking at mortality and the advantages of boosters or not in
Right.
mortality. Think how quickly data and publications are coming to the table now, less than 6 months of
Yeah.
massive studies of 800,000 people versus what used to take 3, 5, 7 years to kind of go from an academic place into publication with a year lead time, and then another 5 years to get out to community docs. So I think science as a whole has been phenomenal, and the medical community's really come together. But I think we all have to keep moving forward and put aside or kind of open up our mind outside of political differences to what's going to be best for the patients and keeping us all safe. And I think it's when people get dug in on things that I feel like we put to bed 6 months ago, that's where there continue to be big issues.
Yeah. Yeah. But even, yeah. Let's talk a little bit about the impact. You know, in the editorial board meeting, we talked about last year. I'm going to get a preview from you. We talked about our predictions for 21, and they were interesting to see what actually we thought was going to happen. And I want to particularly talk to you about the workforce issues, because you know, we saw such a drop off in the number of emergency physician spots in 21, so much so that, I mean, I have, as you know, my son-in-law was finishing his residency in emergency medicine and went into a fellowship. And thank goodness that he had already had lined up a position, but he was letting me know that there were people coming out of emergency medicine residencies who were really good docs who were having a hard time finding a job. I didn't think that would ever happen. You know, it just kept growing and growing, growing. Build it and they will come. Build it and they will come. And it just 21. The combination of the workforce saturation, and I wrote a piece about this. You know, people my age, and you're 10 years behind me, but still people my age hanging in there, still continuing to work, and kind of filling the spots. And these young, well-trained, energetic guys are coming out, and guys and women are coming out, and there's not as many spots as there were. Now, tell me what you think's going to look, 22 is going to look like.
So, you know, I think the workforce issues are challenging and interesting. And let me back up. So in the 5 minutes of preparation I did for our podcast today, I went back and looked at what I wrote over the past year and a half on COVID. I wrote 4 director's corner columns on staffing alone. Salim and I also interviewed who was then ACEP President Mark Rosenberg, where we spent a lot talking about workforce. And of course, ACEP released their projections for workforce saturation about 10 years down the line. And so what we found kind of 20 into 21 was, you know, we had a 50% drop in volume. So we all had to make some sort of adjustment for ER volumes and staffing. And certainly as a director, you're a little bit more fiscally responsible than I would be at a, you know, kind of non-director doc where I just want to do my shift. So I have some fiscal responsibility, whether I'm in a Democratic group, in a contract management group, or an employee of the hospital. There's something going on there. So there was a lot of how do we manage staff, where do we go, and how do we keep our groups busy? And so that's what led to that giant staffing crisis of kind of the summer of 2020, where these graduating residents were coming out. And then going into the summer of 2021, when the next class is there, you know, I hired 2 people. I thought I'd be really overstaffed. But as it turned out, you know, volume mostly came back. It shrunk down a little. And it used to be, like you said, it was build it and they will come, and it was emergency department volume is going to increase 2 to 3% no matter what you do. You just know it's going to get bigger and bigger, and I could always support having at least one more doctor. And now, I've had enough conversations with my boss where I've tried to predict what the volume is going to be in 2 weeks, let alone 2 months or 6 months. I have no freaking idea where I think the volume is going to be. We got back to normal for 3 months, and then I shrunk 5 or 10% again. And I'm trying to balance the staffing and be responsible and protect the patients and worry about metrics and flow. With that said, I think that for the next couple of years, I think there'll be a lot of job opportunities for graduates. And before we get into that 10-year projection, I think what emergency medicine has really figured out over the last year and a half is how do we expand kind of beyond the walls? And this is what Mark Rosenberg talked about, and what I think a lot of companies have. I'm going to use Salim again as an example, but telemedicine. So my group does telemedicine. I started doing telemedicine a year ago or so, for a little bit of experience, see if I liked it. So that's number one. I think there's a lot of telemedicine going on. I think that'll continue. I think in Salim's case, his group got very kind of aggressive with how else they can help throughout the hospital, and Salim has become somewhat of an ECMO specialist and intensivist because of necessity within the hospital. So I think there are opportunities to do things outside of emergency medicine. What I'm seeing now, so there was no movement for a solid year and a half because of the pandemic when it came to jobs, and nobody was hiring. What I'm seeing now is there is some movement. So I've actually had a couple docs leave for different reasons. I've interviewed people from out of state, and they're leaving their groups. And those jobs and those opportunities weren't available a year ago. So it is this kind of domino effect that once somebody starts to move, you do see that you can go out and get jobs. And as we look at the workforce, yes, there's guys like you and me and others that are, older emergency physicians or experienced emergency physicians. And I'll come back to that. I got a funny story I'll tell you. But how long are we going to continue to do this? In this environment? There's very high acuity, there's a lot of volume. And so do I think some people are going to retire probably a year or two earlier? I do, actually. If they thought they were going to work to 65, maybe 63 is good enough. And so for those listening that don't know, and I hope you enjoy this, so I've had conversations with Mark. Mark was one of my night docs in 2006, I believe, so a long time ago.
So you're telling a story about me.
And I did write about Mark. And so, one of the topics that comes up is, at what age can you and your group stop doing nights? And so Mark was my night doc, and somebody would ask that question, and I turned to Mark and I said, man, how old are you? How long are you going to do this? And so the sad part is now, I am now older, I believe, than you were in 2006 when I kind of called you an old guy. And I'm really old now. It's just a little scary.
Oh yeah, that's true. I got into a bad habit. I got hooked on nights, and I liked it. I actually liked the craziness and the independence and the unpredictability of nights. And all you guys were in days were too straight for me. I wanted to.
Right.
especially when we were at Harbor in Baltimore. That was an unusual place.
Right. And I think, part of what kept you sane, and we'll come back and answer the question on workforce in a minute again, but part of what kept you sane is you were not a full-time night doc. You had your hand in a variety of things. And so, and I don't remember exactly how much you worked, but you worked a reasonable number of nights to keep you busy and stay rested. But kind of going back to the question, so I think the workforce is safer and easier to get jobs now. I know I'm hiring a bunch of people, and I think a lot of other hospitals are looking at expansion, and are we building freestanding ERs and urgent cares and other stuff and other places for us to get jobs. I think the issue down the line, I think, is going to be challenging. Where we are in 10 years, there's a lot of new residencies. Everybody's seen that graph where the number of residency graduates is off the chart. I think that is very concerning to me if I was a young doc and if I was looking at specialties and felt like I had some choice. I think most of us that end up in emergency medicine, this really is our calling, and there was no other specialty we were going to do.
I never looked at anything else.
Right, exactly. So if that's what you're doing, this is what you're doing, and we're going to all figure it out. But I do expect to see an increased number of retirements over the next couple of years due to.
I want to say that one of the things tying this into what our start at the beginning of our discussion with the pandemic, as you know, I started after my congressional run. I got more and more involved with the opioid patients and worked downtown Baltimore for a while, and then went out into a private practice setting dealing with the opioid epidemic. And interestingly enough, we hit a milestone, I think this year, over 100,000 opioid overdose deaths in the United States, over 100,000 in 1 year, And we've been doing this for a while, and it's not slowing down. And so one of the things that I am encouraging my colleagues that are my age, number one, is that when they consider slowing down, if they would consider looking at doing an opioid practice. And it was interesting because I found when I went into this area that there were pain docs who were anesthesia, there were opioid, there were substance abuse docs who were coming out of psychiatry and some other things like that. And very few of the docs had the clinical background that an emergency physician had. And I found I was at a tremendous advantage because these are patients I've seen for 40 years.
Right. Yeah.
You know, I know the mentality. I know I've dealt with people like this, and in some cases I realized that it was physicians who actually put them there, or at least started them on the road to their opioid dependency. And so I find that, and the feedback that I've gotten from my patients is that they find me particularly suited to this. It may be me and my personality, but I think that emergency physicians are well suited to make that kind of transition. So when you're talking about expanding outside, Salim's the academician and he's going into the ICU and ECMO. That makes perfect sense. Absolute perfect sense. Okay. I can see you going into more and more administration. You might be the president of a hospital or a system at some point. I think that emergency physicians have, by our nature and our practice and our mental proclivity, the ability to do a lot of different things. And I think that when we look at workforce and we think, oh, we're going to run out of ER positions, I think, no, you're not thinking broadly enough. One of the guys I talked to and did a podcast with up at ACET, he was talking about the fact that they were working with hospitals that were actually in triage, diverting patients out of their ER and sending them to their urgent care. Made perfect sense. Instead of a fast track, they had the option was either to build a new facility or triage them out of at triage to their other facility, and made perfect sense to do that. I think that you're going to see emergency physicians expanding into nursing homes, triaging from nursing homes. There's a variety of different things there. And then also, I'm excited about emergency docs going into opioid treatment. So it was kind of that idea of workforce is almost a softball to you, because
Yeah. Well, I'll take any softball question because we disagree often. But we've talked privately about how satisfied, kind of how professional satisfying you found your work to be in these opioid dependence clinics. I have a fraternity brother who's an ER doc who went into it shortly after COVID. Another former colleague who I've known for 20 years who's doing it full time now. And I think they've said the same thing. It is professionally really satisfying. It's a different kind of stress than the ER. It's more regular hours. And I can assure you, I will never be a hospital president, but I think you'd
be a good one.
Physicians
You'd be a good one.
Thank you. We have a very diverse skill set, and we're very good at communicating with patients and helping them kind of get to the treatment plan that they need. And I think that is another example of an opportunity. It's just like telemedicine. It's another example of taking our clinical skill set and moving it outside of the emergency department to allow us to help people in an environment that probably works a little bit better
Yeah.
when you can't sleep, when you can't sleep at night anymore.
Yeah.
So I think
Yeah.
that's another.
You know what? I found that there was a huge problem in the opioid dependency population in getting in to see somebody. Okay, and if they made up their mind, and what we call a flexion point, they were at a flexion point and they made up their mind they wanted to get into treatment, and they went someplace. A lot of times, all they got was a list of places to call, and nobody could treat them. And so as a result of it, they ended up being discouraged and falling back, and it just never happened. And telemedicine was the gap filler, and by triaging these patients and getting them into initial treatment, that would bridge them into an outpatient setting, I found be eminently successful. And we wouldn't have had that had we not had people like myself and others, I'm not just saying me, but myself and others who had the clinical experience to look at somebody in a screen and feel comfortable knowing what you're going to do with them.
Yeah, right.
If you take a guy who has to have an hour of one-on-one with somebody in order to be comfortable, that he's obviously not an ER doc. We know when there's a problem. No, I'm not going to treat you. You got to go to the ER and have them call me. I've been in that situation numerous times. But there are also times that you look at them and you go, no, we're fine. I think we'll be okay. You're going to call me back in an hour, and they're going to call me tomorrow, and they're going to call me in a week. And then we're going to work our way through this. So I think the point here is I think that emergency physicians are eminently qualified to do this particular job, and better so than many of the people who are currently doing it. So I encourage my colleagues to take a look at that.
That's great.
Absolutely.
All right, what else is on your list here?
Well, I was just looking here at my list, and Omicron. Let's see, what was some other things I wanted to ask you about Omicron. Well, let's talk about Omicron. Let me tell just what we know. What do you think? I mean, I'm going to throw something out there that might hit you kind of crossways.
Shocker.
With the situation with Omicron being highly infective and seemingly, and I will underscore that, seemingly not very dangerous, would it not be in the best interest of people to get Omicron? And don't vaccinate against Omicron, get Omicron. And because we know that natural immunity is better than a vaccine, because we're instead of a vaccine against a single spike protein, we build antibodies to the entire virus. Maybe that's not your perspective, but that's where I come from, and I'm wondering whether it might be better to see Omicron endemic if it's not going to kill you.
So there's probably a few questions in there. Number one is Delta still a solid 99% of what we're seeing here in the States. Will that change in 2 to 4 weeks? Probably. But I wouldn't say, hey, let's go try to catch COVID and take that risk at this point. Number one.
Okay, that's fair.
Number two, there is some population that is going to get sick and probably die. And whether I get it and I'm fine, but I pass it on to my elderly parents, do we want to take that risk? There will be some increase in the death rate if more and more people get it, because it is so contagious and infective. I expect that even if it's milder, we'll still see case numbers go up in terms of death. The mortality may be low, but some percentage of the population, 0.1%, whatever it is, of vaccinated people are going to die. And then number three, I think that the jury's still out on long COVID. I don't know enough about long COVID. I get asked this question a lot on Facebook. I'm an ER doc. I don't see long COVID patients. I don't manage it. I don't have long COVID. I do not want to risk getting it. You lose, even
I
if
hear
you
you.
lose your sense of smell for 6 weeks, 12 weeks, and it comes back, you have 3 months of probably losing weight and not eating and just
Yeah.
being frustrated and miserable. And so I'd like to avoid that as well. Uh, and when you look at natural immunity, while you believe it's better than the vaccine, there's all you have to do is look at some of these pro athletes who didn't get vaccinated and have had COVID twice in 12 months to tell you that either their behavior is risky or natural immunity isn't as good as we think it is.
I thought the Israeli study indicated that it was several times better than vaccinated immunity, and lasted longer and was more complete. But I, I'll have to, we would have to defer to Salim on that.
Exactly what I was going to say. I think my understanding is having natural immunity plus vaccine puts you better than vaccine alone.
I think yeah. Now the question is whether it's significant enough to outweigh the side effect profile, and that's the problem with we don't have the confidence of the public that we've been square with them about the problems.
Mhm.
I have heard this from numerous people. Why is it that if the drug companies are immune from litigation, why is it that they want 75 years before they can open the books on their testing? Do
Right.
you know a reason for that?
And so I'm going to defer to your lawyer hat and say, hey, I'm a simple ER doc who happens to run an ER, and I'm not going to get into big pharma. Uh, I agree that there is mistrust in information, and I
Yeah,
think there's probably some underlying mistrust of the government at all times, but I think there is mistrust in information, particularly over the last 2 years, and
yeah,
it's probably on both sides of the aisle. And I think there's been, decisions that were made that were political decisions and not necessarily medical decision. And it goes back to what I started our conversation with: is I'm glad I'm not in politics and have to worry about the unemployment rate and feeding people. All I have to do is, get my ER prepared to take care of people. It's a much
yeah,
easier decision when all I'm focusing on is what I think is
yeah.
the best healthcare.
Yeah, absolutely. And we're getting to the end of our time here, but I couldn't agree more. I think that, and I will say this again, maybe I sound like I'm beating a dead horse, but I think that medical professionals need to model civil discussion. And I don't think that we always have, at least in the last year and a half or so. And I think that if we can model this openness that you are talking about, I think that will go a long way to calming the fears of our patients, families, those that we influence, like your Friday night following, because I think that just simple um, humility, honesty, openness to things is going to help people to take a deep breath and not think, oh my God, they're trying to kill me.
Right. Exactly. And I agree. I think, being able to discuss this certainly within our professional organization and
Yes.
have a rational discussion. Again, I'm going to defer to Salim and ask him to give me his interpretation of the research. And I think there's a lot of ER docs out there who are,
Yep.
using Rebel EM as a guide for what's best practice. But having those kinds of discussions, I think, is really valuable.
Yeah, absolutely. Thank you, Mike. I always enjoy talking to you. And for those of you who have not always gotten a chance to follow Mike's column, I encourage you to read it, go back and read some of the other ones, even if you're not a director. I think it helps to get into the brain of the director. One of the things that happened when I went to work in Baltimore, I'd been the director of several departments, and because of a variety of things, was I coming back from Iraq or going to Iraq?
Yeah,
I forget.
he's gotten back from Iraq and wanted to start working again in the ER.
That's right. And as a result of that, I wasn't a director, and I was able to go in and really understand what you were going through. And I don't know if I was a great staff physician, but I certainly understood. I certainly appreciated when I saw a good director. And
Well, thank you very much. I think I am a better director because I've been writing Director's Corner, since 2008, and it's really had me think about issues. And I often refer to the column as a little bit of a diary of my life as a chair. But there's other columns where I want to write about something, but I don't know the answer, and it takes 6 or even 12 months to kind of percolate and get my thoughts together to be able to kind of frame it correctly and maybe teach to it a little bit. And then, through those columns, there is my book available that's been out on Amazon for, God, probably 7 years at this point. That came through Plaster Publishing. So thanks for giving me the opportunity to publish that. And the columns are all online and available for people to go back and take a look at.
Yeah. So I'd say to the viewers and the listeners to say, even if you aspire to be a director, you're not currently, and you aspire to being a director, or if you are a director, I would really encourage you to follow Mike's columns and comments, because it obviously puts a lot of thought into it, and it doesn't shy away from, as today, does not shy away from the difficult issues. And these are the things that you as a director will have to face. And it will mean whether your contract survives, whether you have a smooth running emergency department, or whether you have warfare, open warfare in the department. And I think that if you can follow Mike's style and his thoughtful dissection of a problem and implementation of a plan, I think you'd find yourself to be a really good director and an addition to your hospital. So, Mike, thanks for joining me today, and we'll do it again when I want to pin you down on something else.
Thanks so much, Mark. It's always good to talk to you.
It's great. And for all of you that are listening, thank you for joining EP Talk, and join us again the next time. Thank you.